be here. So let's call the meeting to order. We'd like to call the Pension Health Benefits Committee meeting to order. First order of business would be to call the roll. Ms. Hopper, please.
Rob Fechner.
Good morning.
Margaret Brown.
Good morning.
Henry Jones.
Here.
David Miller.
Here.
Irene Ortega.
Here.
Ramon Rubacava.
Here.
Teresa Taylor.
Here.
Shonda Wesley.
Excused.
Karen Green Rochford, Betty Yee.
Here.
Mr. Chair, I believe all is in attendance with Shonda Wesley being excused.
Thank you. And Shonda will be on in a little while. She had a video conference first. So when she comes on, she's going to put it in the chat box that she's back. Item 2 will be the election of the Pension and Health Benefits Committee Chair and Vice Chair. For the election of the chair, I'm going to turn the gavel over to Mr. Rubacava. Mr. Rubacava, please.
Okay, accepted your gavel. So the order of business is the election of the Pension and Health Benefits Committee Chair. Are there any nominations? Ms. Taylor.
Hi, I would like to nominate Mr. Fechner for Chair of the Pension Health Benefits Committee.
Is there a second? David Miller? Seconds. Okay, any other nominations? Any other nominations? Any other nominations? So I guess nominations are closed, and Mr. Fechner, you can reassume your position as chair of the Pension and Health Committee. Congratulations, Mr. Fechner.
So you have to have a vote, Mr. Rubacava.
Sorry. We shall have a vote then. Ms. Hopper, I guess you're calling the vote?
Yes,
Taking the
Margaret
vote?
Brown.
Aye.
Henry Jones.
Aye.
David Miller.
Aye.
Irene Ortega.
Aye.
Ramon Rubacava.
Aye.
Teresa Taylor.
Aye.
Shonda Wesley excused. Karen Green Rochford, Betty Yee.
Aye.
Mr. Chair, I have all ayes. Motion made by Teresa Taylor, seconded by David Miller for the election of the chair of the Pension Health Benefits Committee, Rob Fechner.
Congratulations, Mr. Fechner. Now I can congratulate you.
Thank you, sir. Thank you, Ms. Hopper, and thank you, fellow committee members. I truly appreciate the vote of support. Now, the next up is the election for the vice chair of the Pension Health Committee. For that, I will now open up the floor for the nominations. Are there any nominations? Mr. Miller.
Yes, I nominate Director Ramon Rubacava.
Very good. Are there any further nominations for the office of vice chair?
I'll second it.
It's been seconded. We don't need seconds, but that's okay. Show support. Any further nominations for the office of vice chair? Third and final time, any nominations for the office of vice chair of Pension and Health? Seeing none, I will entertain a motion for Mr. Rubacava to be elected vice chair.
Move approval.
Moved by Mr.
Second.
Jones, seconded by Mr. Miller. Ms. Hopper, please call the roll.
Margaret Brown.
Aye.
Henry Jones.
Aye.
David Miller.
Aye.
Irene Ortega.
Aye.
Ramon Rubacava.
Aye.
Teresa Taylor.
Aye.
Shonda Wesley. Excused. Karen Green Rochford, Betty Yee.
Aye.
Mr. Chair, I have all ayes. Motion made, I believe, by Henry, seconded by David Miller, correct? And it is
Yes.
for the election of the vice chair of the Pension Health Benefits Committee, Ramon Rubacava.
Thank you, everybody.
Thank you. Congratulations, Ramon. I'm going to try and reconnect on my phone. For some reason, it died. I'll be right back here. Hold still. No, it wasn't the phone. It just wasn't on.
can hear you, Rob.
Welcome to Enter ID.
Can you hear us, Rob? Are you there? We see you.
I can hear you, but if I don't get the phone, then you're not going to hear me well enough. So I'm going to try and get the phone hooked on.
Enter your
We can hear you, Rob, by the way, without the phone.
Okay, let's see what happens. Can you hear me now?
Yes, we can.
So now you have an
All right, well,
the phone.
continue on.
You have
I
the
turned the
phone
phone back off.
Yeah, because we can hear you.
All right, well, we'll see how it goes. Next up is the item 3, approval of the March 16th timed agenda. What's the pleasure of the committee? We have a motion?
Move approval. Ms.
Second.
Brown?
Been moved by Ms. Brown, seconded by Ms. Taylor. Any discussion on the motion? Seeing none. Ms. Hopper?
Margaret Brown,
Aye.
Henry Jones,
Aye.
David Miller,
Aye.
Irene Ortega,
Aye.
Ramon Rubicava,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley, excused. Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have a motion made by Margaret Brown, seconded by Teresa Taylor for item 3.
Thank you very much. That brings us to item 4, executive report. First up, I believe, is Mr. Sweeney.
Thank you. Good morning, Mr. Chair and members of the committee. I'm Anthony Sweeney, CalPERS team member. And I'd like to first congratulate Mr. Chair and Mr. Vice Chair on your re-elections, and I look forward to continue working with you going forward. I'm grateful to have survived the last year when I presented in front of you for the first time in my new role as Deputy Executive Officer. And it's a little bit eerie to reflect on what I thought was ahead of us and how it all played out and how far we've come. A year ago, we were just beginning to imagine transitioning into a virtual environment, and now it feels somewhat normalized. The last time I had an opportunity to present before you was in November, so I have a bit more to share today. To start, I'm pleased to report we continue to operate with more than 95% of our team working remotely, and our customer service performance, satisfaction, and benefit payments are being sustained at high levels, meeting and exceeding our goals category. And while our in-person services remain shut down due to the pandemic, the regional offices have still delivered over 45,000 virtual member counseling appointments in 2020, the first year we offered services in this manner. As I've shared previously, we have been concentrating on our customer contact center, where the wait times have sometimes been higher than either we or our members like, especially on the first day of the week. We've been working hard to mitigate these concerns by shifting workload to free more agents and redirecting more team members to the phones on those high volume days. Our strategies are proving successful, with wait times having been reduced by over 45% on the first day of the week since we started our plan about 6 weeks ago. The teams have worked really hard to put these mitigations in place, and will continue to monitor workloads and trends on a daily basis to identify and incorporate new strategies. We wrapped up 2020 with an increase in total retirements by 1% over the last year. Schools and public agencies decreased approximately 7%, while state retirements increase approximately 15%. I've mentioned before, we've seen a huge adoption of our member self-service for retirement applications, with nearly 70% of all retirement applications being submitted online. We've now turned our focus to the service credit purchase process. If any of you have purchased service credit with CalPERS before, you know it was heavily paper-oriented with several back and forths between the member, CalPERS, and sometimes the employer. We have now incorporated many of those functions in the self-service portal. This change enables members to calculate the cost of a service credit purchase and elect from their member self-service account, as well as allowing employers to certify time through their MyCalPERS logins. The first phase of this was implemented in January of 2021, and to date, we have received more than 200 electronic requests to purchase service credit online, representing about 20% of the total requests received since we implemented. As we do with new online offerings, we work with our partners in IT to conduct usability testing. We ask members to use the tool and let us know what they think about the new design. Our initial feedback's been very positive. Everything from I like it, easy to navigate, to it led me along in the process and didn't leave me hanging at any point. And finally, we can do this online. As part of our ongoing strategic goals, we are looking to enhance and expand more services in the online portal going forward. So even in our virtual environment, member education remains critical. In 2020, we've talked about the 2 virtual benefit education events that had over 15,000 class attendees in various offerings. Now we're gearing up for our next virtual CalPERS benefit education event to be held next week, March 24th through 25th. This will be an expanded offering. It will include 20 live class offerings over 2 days and 20 virtual exhibitors in live virtual rooms. It will also have 90 days of on-demand access to these classes for those members who registered for the event. These events keep getting better and better, and I'm really inspired by how they have evolved over the time. I wanted to provide a positive update on an outstanding issue that you may have been aware of in the past that we were recently able to resolve. As some of you may recall, a law was passed in 2007 allowing those who serve in the California National Guard to become CalPERS members. However, at the time, there was no method in place to report that service to CalPERS. The National Guard's a federal agency whose payroll methods differ from state agencies, and the California Department of Military is responsible for reporting the National Guard's payroll. But they are federal employees, and the military department did not have access to payroll information. This resulted in having no way to report critical attributes for CalPERS pensions to us. While it took some time, I'm happy to report that through collaboration between multiple parties, including the State Controller's Office, the military department, and our internal CalPERS teams, we began accepting contribution reporting data in our MyCalPERS system, enabling California National Guard members who have chosen to be enrolled in CalPERS membership to now have an automated process for payroll and service credit reporting. Additionally, members can now also purchase past service credit as well. To date, we have approximately 25 National Guard members accruing CalPERS service, with nearly 40 more pending information from the military department. It's nice to finally have these automated capabilities between our various departments. Lastly, I wanted to share a special member story with you. It's been such a strange year and one that's given us plenty of opportunity to meet members' needs in new and creative ways. Our Walnut Creek Regional Office had become aware of a member who had lost his housing and after hospitalization resulting from severe health issues, had been discharged to a live-in care facility, unable to care for himself. With live-in care facility restrictions in place due to the pandemic, the member did not have access to visitors, and he also did not have a mobile phone and had limited means of communication. In January, a medical social worker with Kaiser contacted us for assistance in helping the member access his retirement benefits due to his disabled state. Since then, several members of the CalPERS team have coordinated with the care facility and Kaiser to help the member, including the arrangement of witnessing the signature of his retirement application virtually. I'm happy to say, through the earnest efforts of many dedicated and caring people, this gentleman is now receiving the benefits he has earned as a public servant. This story is an example of how extremely proud I am of our team for managing the current environment and delivering on our mission of serving our members and employers. Our team has dealt with multiple challenges, but they continue to be resilient, and our leadership has continued to be flexible with our team members. To date, this flexibility theme has worked, enabling us to fulfill our mission and provide exceptional customer service, while also allowing our team members the balance they need to manage their home lives. We hope to carry that momentum into the future with the combination of telework and working in the office, letting the team have a say in what their post-pandemic work arrangement will look like. I wish to thank the board for your continued support as we've navigated this bizarre year. And this concludes my update, and I'm happy to take any questions.
Thank you, Mr. Sweeney. Appreciate the update, especially the part about the National Guard, and more importantly, the dedication that you guys put into getting that member retired. So thank you to you and your staff for always being flexible and making sure that the members come first. Seeing no questions, then we'll move to Mr. Molds.
Great. Thank you. Good morning, Mr. Chair and members of the committee, Don Molds, CalPERS team. I also want to congratulate Mr. Fechner and Mr. Rubalcava on your reelection as chair and vice chair of the committee. Our team looks forward to working with both of you again this year. I'll start my remarks by providing an update on timing for the long-term care rate increase you adopted last November. We communicated with you that the increase would take effect sometime after July 1st, 2021 for the first year increase and late in 2022 for the second year increase. We now know that the first year increase is set to commence in November of 2021. The timeline for the second year rate increase has not changed. This means that the offer letters to policyholders will be mailed this August. These are the letters that policyholders receive with specific policy change offers that, if accepted, would allow them to avoid the rate increase entirely. The offer letters will also remind policyholders of their right to contact our third-party administrator, long-term care group, to arrange customized changes in benefit. The delay of the first year increase, the delay in the first year increase from summer to fall was necessary because of significant upgrades we've instituted in the offers we're providing to our policyholders. In the past, policyholders received the same offer regardless of the specifics of their policy. These options will be provided, the options we'll be providing in this rate increase will be tailored to individual policies and afford options for two options for many policyholders. The tailored offers will help policyholders get more from their amended policies. The addition of the policy options you approved in November and the decision tree we've integrated into the benefit offers require extensive coding changes, which is the primary reason for the added time. The modest delay is not significant enough to require changes to the size of the required rate increase. I also want to mention a trend that's been reported recently in the news and in the earning reports of some publicly traded long-term care insurance carriers and how it could potentially affect our needed rate increases. As I've mentioned in the past, COVID has disproportionately killed individuals who are of the age where they require long-term care. And more specifically, it has killed residents of long-term care facilities at a very high rate. COVID has also made people more reluctant to use long-term care services, both to have a long-term care provider coming into their home regularly or to move into a long-term care facility. Few publicly traded long-term care carriers have recently recently reported that these trends have reduced their short and long-term liabilities. We're currently monitoring for this trend. To date, CalPERS has not seen material changes in either deaths of their policyholders or in deferred claims, though claims lag may be blinding us to some of these changes, particularly to premature death in our enrollees. It's also worth noting that any slowing of the use of long-term care services is likely to be short-lived. As long as long-term care workers and aged people are vaccinated, the risks associated with receiving services has gone down. And as anxieties associated with the use of long-term care services goes down, industry experts expect a return to regular use patterns. Any reduction in liabilities we do see will be passed along to our policyholders, most likely in the form of reductions in the second year rate increase. We'll let you know of any developments related to this issue. The next item I want to share is that we are underway with our risk mitigation strategy as part of the 2-year implementation of portfolio rating for our basic health plans. This includes the development of risk scores for each of the health plans. As a reminder, we're calculating risk scores using the Milliman Advanced Risk Adjuster that was approved by the board in November. We shared preliminary risk scores with the plans in late February. Over the next several weeks, we'll engage with the plans as part of the rate development process. Each of the plans' final risk scores will be made available at the end of April and shared publicly on the CalPERS website. Next, I want to update the board and our stakeholders on our continued important efforts on behavioral health. I want to thank our board, stakeholders, and members for their input on our work to increase quality and access of behavioral health services for our members. I also want to acknowledge Controller Yee's recent letter on this topic and let you know we remain steadfast in our focus on making sure members have access to the right kind of clinical behavioral health care at the right time. Dr. Logan provided an in-depth look at our work on behavioral health in January, but I'll quickly highlight a few key actions underway. Behavioral health is an essential part of our strategic plan. We're monitoring behavioral health claims and utilization and identifying trends and areas we may need to address with plans. We've seen a significant uptake in the use of behavioral health services during the pandemic, including an exponential increase in the use of behavioral health services through telehealth. At the same time, we've not noted any increase in grievances and appeals during the same period, which helps to reassure us that our focus over the last few years to improve quality and access is helping our members. We anticipate that telehealth will continue to play a vital role in behavioral health treatment for our members after the pandemic and have embarked on a significant research agenda that will be aiding our efforts to harness the best telehealth has to offer while avoiding some of its downsides. We continue to work with Covered California and the Department of Healthcare Services on a plan to improve behavioral health infrastructure statewide. This, we believe, will be the key to any truly meaningful change in quality and access. More recently, we've added behavioral health performance measures to our health plan contracts for 2021. This is just a glimpse of our broad set of activities. Dr. Logan and I will be providing you with regular updates on our work in behavioral health on an ongoing basis. With the continuation of the pandemic and the corresponding rigors and stresses we've all been facing, we're acutely aware of the importance of behavioral health within the CalPERS Health Program. Last for me, I want to share that this year open enrollment will be held from September 20th to October 15th. These dates are similar to last year's open enrollment timeframe. With the various plan expansions and benefit additions you've approved, we'll have our hands full this year. Dr. Logan is here to provide you with the COVID update. I can answer any questions now, or I can wait until after her remarks. It's at the pleasure of the chair and the committee.
Well, we do have a number of questions for you, but I wanted to let Dr. Logan go first because there may be questions in there as well.
Great.
Great, thank you. Can you hear me? Yes, great, thank you. And good morning. Julia Logan, CalPERS team. It's been a remarkable few months in the fight against COVID-19. Over the winter holidays, we witnessed a horrific surge in California. Southern California became the epicenter of the pandemic, and vaccines were scarce. Fast forward to today, and more than 12 million Californians have received at least one vaccine dose, and our COVID cases have dropped to levels we haven't seen since October. Over 1,200 providers across the state are administering vaccines. The state expects to have 3 million vaccines administered a week by the end of March and 4 million a week by the end of April. President Biden's $1.9 trillion American Rescue Plan Act will help to accelerate and amplify the state's efforts. The stimulus includes $76 billion for COVID testing and contact tracing, vaccine distribution, and the distribution of other medical supplies. Earlier this month, Blue Shield of California, under contract with the state as its third-party administrator, launched its centralized statewide vaccination program. Blue Shield will build on the state's existing capacity and vaccination processes that are working well, while enhancing state oversight of the vaccine supply and accountability for all vaccine doses. Using data-driven targeting of hotspots, Blue Shield has created an algorithm to determine where to allocate vaccines statewide with a focus on equity. The state is directing 40% of vaccine doses to disproportionately impacted areas of the state, reserving appointments for members of these communities and increasing funding for safety net providers. Just yesterday, vaccine eligibility opened up to more Californians. In addition to certain essential and emergency workers and those over 65, individuals ages 16 to 64 with high-risk conditions are now eligible to receive a vaccine. This means that roughly 18 million Californians are now eligible to get a vaccine. Currently, there are several ways to find an appointment for a vaccine, and we recommend that members who are eligible check first with their usual care provider to see if they have vaccines and available appointments. Providers who have vaccines may also begin reaching out to you to schedule your vaccine appointment. Members can also check their local pharmacies and their local health departments to see if they have vaccines and available appointments. In addition, throughout the spring, as vaccine supply increases and the statewide vaccinator network grows, you'll be able to schedule an appointment through California's MyTurn, their vaccine enrollment website. The website is www.myturn.ca.gov. And with more than 105 million people across the country receiving highly effective and safe vaccines and COVID cases dropping, questions have come up about a post-vaccine world and what that may look like. Last week, the Centers for Disease Control and Prevention released recommendations for fully vaccinated individuals that provide some hope. According to the CDC, fully vaccinated people can visit with other fully vaccinated people indoors without wearing masks or distancing. They may visit with unvaccinated people from a single household who are at low risk for severe COVID-19 disease indoors without wearing masks or physical distancing. They may also refrain from quarantine and testing following a known exposure if they remain asymptomatic. While getting shots into arms as quickly as possible is extremely important in getting us back to a sense of normalcy, we are not going to completely eradicate COVID. We will still need to continue to adhere to public health measures, remain vigilant and humble, and we'll need treatments for those who don't respond to vaccines or who haven't yet received a vaccine. And there's hopeful news on the treatment front as well. New pills to treat patients with COVID-19 are currently in clinical trials, and if successful, could be ready by the end of the year. This treatment is a pill designed to do for patients what the drug Tamiflu does for patients with the flu. Positive results were seen in early trials and could prevent hospital stays and help people get better faster. We realize that for members, trying to track vaccine development, eligibility, and supply can be challenging and often frustrating. To keep our members and stakeholders informed, we have been giving regular updates on COVID-related issues at stakeholder meetings and have been keeping information on our CalPERS website up to date. We also continue to engage with our health plans on COVID-related issues such as vaccine availability and distribution, as well as ensuring that members get the care that they need in the right settings during the pandemic. While our health plans do not have direct control over vaccine supply and eligibility, they do play an important role in educating members about the safety and efficacy of the vaccines and in the administration of the vaccine. Our plans are engaging members to provide up-to-date information through direct outreach, vaccine hotlines, and their websites. OptumRx, our pharmacy benefit manager, has set up a reminder calling system to help remind members that they need their second shot. Thank you for your time and attention. I'm happy to answer questions. Otherwise, I can pass it back to Don.
Thank you for the presentation. We do have a question for you, Mr. Miller.
I was just curious, Dr. Logan, I noticed there were quite a few reports in the news about local or municipal authorities who were questioning or kind of balking at participating with, I guess it was Blue Shield's system. And what were their concerns? And is there anything we should be worried about with regard to that?
Thank you for the question. I was not aware of their concern. Maybe Don, if you are aware of it.
Yeah, sure. I can say that there have been some transition complexities, is I think the kind way of putting it. The challenge in starting a statewide third-party administrator to centralize vaccine distribution is that you're doing it after vaccine distribution has already started. And so, the governor had a vision for this that involved building on existing pre-built infrastructure, but also making the process much more uniform. So that is always going to involve some back and forth between the existing infrastructure, which has largely been county-based, and the new infrastructure, which is more centralized. So, you have heard from time to time some of the counties concerned about doing things differently because they, in their mind, I think, have worked through some of the kinks and have something that they see as working. And that's been most of what has been vocalized. And I can say, just having watched it and talked to some of the folks who are implementing, that the effort here is to take the best of what's built and to implement on top of that some really critical goals. These are the goals to increase the speed of the distribution, goals around the equity of vaccine access, and so forth.
Great, thank you. That's very helpful.
Thank you. Mr. Rubalcaba, is your question for Dr. Logan or for Mr. Moulds? Because I have a list.
I'll start with Dr. Logan's question issue first, and then I have another one later from Mr. Mould. Thank you, Mr. Chair. I want to follow up. Thank you, David, for asking the question. I was going to ask the same question, so I'm not going to repeat it. But I also understand on the Blue Shield, LA County is one of those counties that is bulking as to why they need to coordinate with Blue Shield. But there was also a lot of news reports that the contract with the state and Blue Shield wasn't clear what the role was and that it was being amended. So can you give us a little bit, either Dr. Logan or Mr. Bolton, what is the official role of Blue Shield as third-party administrator or administrator, and what does it entail? Because I guess one of the concerns was what kind of data were they tracking and sharing? If you could speak to that one, please, somebody. Thank you.
Yeah. Dr. Logan, do you want me to take that one, or do you want to?
Sure, I can start, and then if you want to add.
Great.
Yeah, so the role of Blue Shield was really to centralize what's happening in the 58 counties and the other local health jurisdictions, as well as the other providers who are administering vaccines. So there's a lot of accountability that they're doing and oversight that they're doing that wasn't happening in a centralized fashion with the individual counties and vaccine providers. So they're enhancing the state oversight of vaccine supply and increasing accountability for all of the doses. As you remember, a month or so ago, there were issues with the amount of doses that were allocated for the state, but not actually being put into arms. And so those issues with Blue Shield on board have been resolving, and they're able to just be much quicker in kind of their oversight and administration of the doses.
Thank you, Ms. Dr. Logan. But if you could speak also to, is a contract, have you seen the contract? Is it public? What are your, I mean, because I understand it was not available at first and then it was amended, but I'm not sure what the latest is on the contract between the state and Blue Shield. If you could speak to that question, please.
Yeah, we haven't seen a contract. But that's not to say that the contract doesn't exist. We just, it's not a contract that's involved us. I know that it was that the contract was somewhat iterative. So we can certainly get back to you as to where it stands right now. But they've started this very quickly, moving very quickly, it's been reported out in fits and spurts, but certainly happy to get back to you with the answer to the question of sort of what's public out there right now with respect to the contract. I can tell you, just to reaffirm what Dr. Logan says is that, one of the key roles that Blue Shield is playing right now is this oversight role, which is really critical. They have been moving vaccine from places where distribution has been slower than it should be to places where it's quicker. They've been moving it to address some of the equity issues. So certainly on the supply side, they're playing a very major role.
Thank you, Mr. Nguyen. And Ms. Ortega just on the chat shared the contract, and actually I was looking at the scope of work. So thank you very much, Mr. Ortega. Thank you, Mr. Ball. And I do have a question later, Mr. Fechner, when we get to off the COVID issue. Thank you.
Very good. I think that's all for you, Dr. Logan. I will go back to the questions for Mr. Moulds. First, I have Ms. Green-Ross.
Thank you, and thank you, Mr. Moulds and Dr. Logan. The controller's concern was just about everything we've been hearing and reading about the escalation in COVID's second impact on mental health, besides the physical impacts. Just seemed excessive from everything we've been reading and hearing, and we know the team has been working on it. So appreciate just having regular updates, and if you are able to share what sort of performance metrics you're putting on our plans, that would be helpful to know so we can see how we're going to track that. Much appreciate that. And my second comment, we were contacted from several folks about on the long-term care program rate changes and the impacts of COVID. So I appreciate the update about that, and that you'll obviously, it'll remain to be seen if there's any sort of long-term impacts, and appreciate that you will be considering that for the second round of rate increases. So thank you.
Thank you. Ms. Brown.
Thank you, Mr. Chair, and congratulations. My question is also on long-term care. I have heard from a number of members about the rate increases and sort of the process by which we are giving them specialized rates, so maybe their rates don't increase as much or at all. Can you tell me, Dr. Moltz, about how many or what percentage of the insureds you've heard from about tailored offers or tailored efforts? I mean, is it half? All?
We've heard from very few. Very few. Episodically at this point, we've gotten contact. We received contact from policyholders about their rate increases, largely and certainly understandably expressing frustration over the fact that we need to raise rates. The process for the rate increase, while we've been putting up information on our website, we've been talking with the stakeholders who in turn have been sharing information in their newsletters, but we expect that a good percentage of the policyholders are probably at this point unaware of the forthcoming rate increase. We send in a few months, we will be sending out letters formally letting them know. Those are ahead of the offer letters that I mentioned that will give them their buy down options. But the buy down options are where we would expect them to engage with long-term care group in working through customized approaches if that's what they choose to do. That's historically been the experience. So in terms of percentages of policyholders who would be seeking some sort of customized approach, it's really too early to tell. I can tell you historically, just looking back at the last rate increase, it was a relatively small number of policyholders. The vast majority either took the rate increase or took the offer that we sent in the offer letters, which is part of the reason that we wanted to make sure that the offers were thoughtfully constructed and tailored to the specific policies of the beneficiaries.
I appreciate that. My concern is that I want us to be noticing the members sooner rather than later. I know we have legal obligation by the contract in terms of how many days in advance we must notify them, but I really want us to notify them early enough so they can start planning and maybe making different choices once they realize that their policy could be going up, 50%, 80%, whatever the percentages are. And so I just want us not to wait to the last minute to notify them.
So I'll just say I completely appreciate that. I did not want to send a letter to our policyholders about a rate increase until we had nailed down the exact date of the rate increase. The last thing I want to do is give them partial information or information that may be subject to change. So we had looked at sending the letter earlier in the spring to notify them of the future rate increase, but I held that because I wanted to wait until we had specific information that was hard with hard dates.
So thank you. Are we going to do a new actuarial study based upon sort of the changes in uses of long-term care or the number of people who've passed away who maybe are no longer on our long-term care program? And the reason I'm asking that we do that is just like we've done for the East San Gabriel Valley people with their pensions, we did another actuarial study to make sure we could give them the most pension or give them the least amount of reduction. I'd like us to do the same with the long-term care, that we seriously look at that and maybe even hold off on increases this time around until we get that additional information to us and the stakeholders. I'm telling you, people are 100,000 or so members are very, very concerned about what they're going to be doing in the future.
Sure. Yeah, we do. We run an actuarial report looking at everything from the state of our returns to our mortality, morbidity, and lapse rates, and update our assumptions in the long-term care program on an annual basis. That's that work is led by the actuarial team. So we will that will be done before we implement this coming rate increase. I can tell you that we've been, when I say that we've been monitoring for the possibility of changes in our liabilities due to COVID, we have data from the spring surge that just didn't show meaningful differences in mortality or claims. I speak with long-term care group that sees claims coming through as they come through. We have not seen, I spoke with them last week, I spoke with them 2 weeks ago. We have not seen meaningful changes there. The one place where we might be more likely to see changes is in mortality. And a lot of our policyholders are billed on an annual basis. So lapses due to mortality may not be things that we see until the next billing cycles. When I checked with our actuarial team a week ago, as I'm doing with them also about mortality, they are still not seeing meaningful difference, but that's not to say that it won't happen. The risk in delaying the rate increase is that the longer we delay the rate increase, the more of a rate increase we have to implement. So as we, every month that we're not putting forth the rate increase is a month where we're not collecting the additional premium, and it increases our liability. So, it is something that we're paying close attention to, because if there are significant changes, we're going to want to make the adjustments. But it also wouldn't make a lot of sense to put off our rates significantly, because ultimately, when we do the rate increases, we'll just need to go forward with higher rate increases, and that's something that I think none of us want to do.
Thank you for that, Dr. Moltz. I have an accounting and finance background, so I do know that putting off budget cuts or increases do delay and cause greater harm later. The question about the mortality and the billing being annually, can we look at that ahead of the annual billing? I mean, I know we get, sorry to say, we get a death roll from Social Security, or we get it from someone. Can we use that in order to look at mortality instead of waiting for the annual billing cycle?
So some of it we will see, some of it we can see that way. We can't look at our own data because this is a completely different population than the CalPERS membership. So a minority of long-term care policyholders are actually CalPERS members. We can't get accurate data looking at our own records that way.
I appreciate your answers, and I just hope it sounds like we're doing everything we can to stave off huge increases to our long-term care members. And then, Mr. Fechner, I know that there are a couple of callers on the line who'd like to talk to Dr. Moltz. I don't know if we're going to let them go out of order, but hopefully you'll call on them when all the board members are done asking their questions. Thank you.
They are on the list as soon as we're done hearing from committee and board members.
Thank you.
Next, I have Mr. Rubalcaba.
Thank you, Mr. Chair. Mr. Dunn, I had a question on the behavioral health. First, I want to also thank Controller G for her advocacy on this issue. Mr. Moltz, you mentioned that there were some efforts underway to to work with some other parties to improve the behavioral health infrastructure. Can you expand on how that will be done? Because at least for most of our members, it's through their medical plan who provide that service. So they contract with, either they have it in-house, like say Kaiser does, or they contract with the other providers, the insurance company. So how would that, what are you looking at?
Yeah, I'm happy.
Independent carve-outs or something like that? I'm just curious.
The mention of Covered California and Department of Healthcare Services was, so basically what we're doing is so combined. I've said this before, but the three of us, CalPERS, Covered, and Medi-Cal, comprise more than half of the total non-care lives in California. We're 16 million strong across the three of us, which gives us tremendous leverage in the marketplace. And one of we all use many of the same providers in our networks. And the challenge historically is that we've all been asking those providers to do different things. We've measured their successes in different ways. And so you have providers that row one direction for Covered California, a different direction for Medi-Cal, and so forth. And there's tremendous power in identifying the right metrics and then all asking for the same thing. If you have more than half of the purchasing power in California asking providers to do exactly the same thing, it's far more likely to happen. So that's part of it. Part of it also is thinking about larger efforts to expand the workforce. This is an area that's challenged. Part of it is pooling our resources to understand better how to maximize the use of telehealth in productive ways. So, as Dr. Logan has said before, and as I've said before, telehealth is a real winner for behavioral health. There's a lot of evidence that suggests that lots of people who are uncomfortable getting in-person behavioral health services will use telehealth to get those services. It's also challenging because particularly in rural areas, behavioral health services are often not available or they're really hard to get to. So you have to drive a long way. If you're doing it regularly, that creates challenges. So, aligning with Covered California and Medi-Cal and focusing our efforts in the same direction is going to lift all boats and we think improve behavioral health services for all of our enrollees or members and so forth.
Mr. Moles, I thank you for taking the initiative to work with other partners, especially this big, to try to improve the access for everybody. So I thank you for that.
Yeah,
I do have one more question on something else. In your report on risk mitigation, you're talking about the sharing of risk scores. Well, risk scores and the risk pool is a big element in what we're trying to figure out how best to, what are the most appropriate way to arrive at a justified premium rates. The COVID situation has also impacted utilization, reduced it in many areas. And so I wonder how would that counterbalance the risk scores? I mean, wouldn't that be sort of, I mean, in a way it sort of mitigated the risk pool, didn't it? So I was wondering how we're preparing to deal with that issue about COVID, COVID impacting utilization in a favorable way. And how would that play on the rate calculations?
Yeah, that's a great question. I don't want to get too granular, but you asked a granular question, so forgive me. But the way that risk scores are developed is that typically the entities that develop them identify conditions or use patterns that are essentially proxies for future increased risk. So COVID because COVID is more of a point in time, COVID would not be one of those conditions. It doesn't mean that COVID isn't a confounder when it comes to risk scores, or that there isn't overlap, because as you know, having, say, diabetes or obesity is a risk factor for COVID, and potentially used in risk scores, especially diabetes. So they're different, but COVID, COVID is as I said, it's a confounder that we've talked to Milliman about how they account for COVID. They have looked primarily at data pre-COVID, so 2019, in development of some of their risk scores, and then they try to disaggregate COVID out of it. So you would presumably discount for things like, or you would pull out things like hospitalizations related to COVID, because hopefully they are not indications of future medical liabilities.
Thank you.
Thank you, Mr. Mould. I do want to say these are some pretty deep topics for executive reports. So can we look at putting these on a future agenda item to discuss the behavioral health and mental health issues with the different plans, et cetera, as well as the risk mitigation?
Sure. Point taken, and happy to.
Very good. Next, I have Ms. Ortega.
Thank you, Mr. Chair. I just wanted to say that the Blue Shield contract is available on the public website of covid19.ca.gov for those listening.
Excellent. Thank you. I have Mr. Jones.
Thank you. First of all, congratulations to the chair and vice chair on your re-elections. And my question is to Mr. Mose. I did hear that you said that I think I heard that the letters will be on the long-term care program. The letters will be mailed out in August, but I didn't hear the deadline date. And also, when the members select an option, is the effective date is when their election is received, or are all members going to be modified on the same date at some deadline date?
Yeah, so both good questions. The letters in August are the offer letters. There will be a letter that predates that letter, just informing members of the rate increase. But the offer letters are the ones that require the customized use of the decision tree. So they really can't go out any sooner. The vast majority of so billing, because this is such an old program dating back to the 90s, the billing cycle structure is different for different members. Most of the bills will go out in November. We anticipate about 80,000, actually a little over 80,000 of those bills would go out right away in November. So some bills, because of other reasons, they're on a different billing pattern, would go out a little bit later, but as I said, the vast majority in November.
So is there a deadline date in which a person could exercise their options?
So they have 60 days to exercise their option.
60 days from receiving the letter?
Correct.
Okay. Thank you.
Thank you. Mr. Miller.
Yeah. Mr. Moulds, I just kind of an observation, and it may be a little premature for us to really be thinking a lot about this, but kind of you mentioned the kind of post-COVID world where we see, for example, in long-term care that maybe the people being more comfortable going back to it, or also with healthcare in general. I think a lot of people may be deferring care or deferring procedures, or that may seem like a short-term savings, you know, but really for people with chronic conditions, avoiding healthcare, you know, may impact usage and costs in a negative way in the future. But one of the things I kind of wanted to bring up and point out is, while there are some real common impacts between, say, long-term care and acute care, or even almost anything in healthcare, where they've had to invest a lot in capital costs, infrastructure changes, everything from facilities to HVAC and existing facilities and everything because of COVID. The impact of those costs on their business models and finances may not appear to us via providers or insurance or our negotiations for a while. And even things like right now, the labor costs. In California, the cost of agency nurses recently exceeded $200 an hour. And I know it's been a really huge challenge and concern because they've had a lot of capacity issues with their workforce. But in contrast, in long-term care, their challenges, and it's an industry that's nearly in crisis because they do not have the kind of financial structures to be able to, for the most part, balance payer mix and the different margins of their different service lines, because they have very few. And a lot of them, you know, are potentially going to be blinking out rather than recovering. And I think that's something in a kind of a longer, you know, 1 to 5 year is going to impact us and impact our members, and it's going to be of great concern. So
yeah, so great point. Great points, I should say. You put your finger on a number of issues that have that have sort of popped into my head in the middle of the night and kept me awake. You know, it is I would say the main reason. I will say this first. I'm extremely worried about the future environment for long-term care for many of the reasons that you just identified, but also because of a lot of regulatory uncertainties. As we rightly so, as we think about the future for long-term care facilities, in the interest of avoiding the kind of mortality that we saw over the last year in long-term care facilities, I cannot imagine not seeing new requirements about spacing and ventilation and all the kinds of things that you mentioned. And we also know that there's going to be massive consolidation in the industry. And as we know, that's never a good thing on price. So, you know, this is the reason that we are moving forward on the aging in place strategy, which is also a managed care strategy, and is also what we are hoping to put in front of our policyholders to avoid some or potentially even all of the second year rate increase. You know, the winner for everybody in this kind of environment is providing options for people to age in their own homes, to decrease the pressure on facilities going forward, and to improve, you know, our future financial picture at the same time. So that's where we're headed to address some of these challenges. But I think you're right in having concern about them. I certainly do as well.
Yeah, well, I don't want to say I'm glad that it's keeping you up at night, but I'm glad that, as usual, you and Dr. Logan and the whole team are, you know, really on top of all this, and that we're thinking beyond just the immediate circumstances. So thank you for that.
Thank you. Mr. Ruffino.
Thank you, Mr. Chair. And first, congratulations to you and the co-chair on your election. A mental health crisis was looming even before the pandemic hit. And now more than ever, I think our members need more support and more resources than ever before. So the treasurer is requesting CalPERS to perhaps schedule, and as has been said, another hearing in the near future regarding the access of mental health and get an update, for all the healthcare providers as we did a year ago, and to see where we at. And so just wanted to ensure, that we made that request to you, Mr. Chair, and to the committee. Thank you.
Thank you, Mr. Ruffino, and thank you to Ms. Ma as well. We've also had that same request from Controller Yee, Mr. Rubalcaba, a couple other board members. So Mr. Moles knows that he's going to put that on a future agenda, and we're going to tackle that issue. Seeing no other requests from the board to speak at this time, Mr. Fox, I understand we have a couple of folks that wish to speak from the public.
Yes, Mr. Chair. We have two callers for Don Moulds. Comments to Don Moulds. Mr. Tim Behrens from CSR.
Good morning. Can you hear me?
Good morning. We can hear you just fine.
Thank you. This is Tim Behrens, California State Retirees. Congratulations, Mr. Fector, Mr. Rubakova. Thank you for the opportunity to comment. I want to address the long-term care insurance decisions this board approved in November. We appreciate Dr. Moll's willingness to delay the implementation date of premium increases in order to offer another option to subscribers to mitigate premium increases. I would point out, however, that in order to have no increase, a member would need to select options which would significantly reduce the value by close to 50% of their coverage after many have reduced coverage from past premium increase events. Case in point, one of our CSR members who purchased long-term care insurance at its inception for he and his wife, out of concern for their later years, in 2013, they chose to reduce their benefits to 10 years with no inflation protection, and still their premiums rose to $227 per month each. In 2019, their premiums increased to $448 per month each. The actions you approved in November will raise their premiums to $851 each. To mitigate that, they would have to reduce their coverage to what they may consider unacceptable levels. A likely outcome for them and many others will be terminating or letting their policies lapse. They will lose all of the thousands of dollars they had prudently, they thought, paid to protect their assets if they needed long-term care. Ironically, higher lapse rates, a likely result of the 90% increase over 2 years, will actually help the fund since it will retain all contributions and not have to pay claims for those subscribers. In November, CSR expressed concern over the rate increases and benefit reductions, but stayed neutral on the proposed action because we understood the challenges the fund and CalPERS faced. In light of new information, however, we now oppose this large increase and ask the CalPERS to further evaluate and reconsider the need for any increase, and certainly not 52% this year. This new information is from various sources, which Larry Wookson will detail for you in his comments. They include large savings due to the COVID pandemic, better than expected long-term care investment returns, and many uncertainties about future nursing home usage. Larry's sources include long-term care commercial providers, quarterly reports, industry analysis reports on COVID pandemic effects, and the American Academy of Actuaries report titled Impact of COVID-19 on Long-Term Care Insurance. Larry has requested 5 minutes to present this complex data. I hope the chair will grant the extra 2 minutes. Thank you. Have a good day and stay safe.
Thank you, Mr. Behrens. Mr. Fox?
Hello? Hello?
Hello?
Hello?
Hello?
Hello? Can you hear me?
We can hear you.
You can hear me?
Yes.
Okay. Thank you. Mr. Fechner, congratulations, and to Mr. Rublikava as well. Am I able to speak for 5 minutes?
Yes.
Okay, thank you. First of all, I'd like to say that Dr. Moles addressed a number of issues that I'm going to raise, but I do feel that I have some disagreement with some of his statements. So let me start by saying, as of March 10th, 54,621 Californians have died from COVID-19. 12,905 of those, or 24%, were in nursing homes. The mortality rate alone represents a cost decrease for LTC insurers over the last year. Breakdown by funding type isn't available, but Medicaid patients would likely be higher. But I have found cost savings from numerous commercial LTC insurers, which would be most similar to our CalPERS claimant population. One carrier group, Unum Group, announced claimant mortality increased by 30% in their second quarter, yielding a positive quarter. And I apologize for that characterization. And they described new claim incidents also as favorable, meaning lower, driven by what they believe is a hesitancy toward nursing homes. American Enterprise reported operating earnings of $17 million, big increase for their second quarter in its long-term care segment, based on a drop of policyholders entering nursing homes and increased mortality-related terminations. Genworth Financial also saw terminations significantly higher in second quarter. One analyst, Piper Sandler, states, quote, the need for LTC rate increases may be actually greatly reduced. Another analyst, Andrew Kligerman, says he expected the lower claim levels to continue the rest of the year. Also, not mentioned yet, is the disproportionate number of COVID deaths among the elderly not yet in need of LTC will contribute to fewer claims in the short to midterm. Note that this information comes from carriers' second quarter reports, well prior to the enormous mortality spikes since. Lastly, according to the American Academy of Actuaries report, economic conditions and fear of LTC facilities may cause short to longer term lapse rates of policyholders. Higher lapse rates equals lower cost for carriers. The combination of all these factors brings significant cost relief in the short term, likely much longer. And as Don said, none of this COVID information was considered or available to CalPERS when completing its latest actuarial valuation report, on which it based its 2-year 90% premium increase, compounded 90%. Even now, COVID data specific to our subscriber population is limited due to the 6-month data lag that Don mentioned. So while some industry analysts may predict cost increases in the long term and return to normalcy, the Academy of Actuaries report actually suggests that lower costs may continue. There's great uncertainty, but income and or increase in home health, which is half the cost, may be an outcome. So finally, I want to cite important additional data. None of the 6 LTC agenda items analyzed for September and November committee meetings, while painting a bleak picture of investment returns, reported this figure that I found on page 4 of the full 62-page actuarial report. Quote, the program experienced an investment return of 7.1% during FY 18-19. Remarkably, that's nearly 2% above the 5.25 discount rate, which you just lowered, which largely contributed to a 90% increase. One final figure, the board members may not be aware of. During our March 3rd retiree roundtable, I learned from Dan Bienvenu that the most current status of the LTC fund total assets now stands at $5.3 billion. It's a 12% increase over the $4.73 billion in assets in that report on which these increases were based. We urge CalPERS to delay any increases in premiums till staff can accurately evaluate the COVID impacts, the influence of a much higher total fund assets, and reevaluation of the need to lower the discount rate based on a 7.1% recent return. Thank you.
Thank you. Seeing no other requests to speak on this item, Mr. Fox, is there anyone else on the line?
Mr. Chair, no, that concludes public.
Very good. Thank you. Before we go on to the next agenda item, I just want to note for the record that Ms. Wesley has joined the committee. So welcome this morning, Ms. Wesley. Brings us to agenda item 5, action consent items. Having no request to move anything, what's the pleasure of the committee?
Move approval.
Is there a second?
I'll second. Ramon Rubalcaba.
It's motion by Ms. Taylor, seconded by Mr. Rubalcaba. Any discussion on the motion? Seeing none. Oh, Ms. Brown?
Yes. I'm sorry. Can you tell me which items we're voting on? My diligent went down.
5 action consent items. 5A, the approval of the November 17th committee meeting minutes. 5B, review of the Pension Health Committee delegation. 5C, minimum standards for health benefit plans, amendment of regulations.
So I need 5C broken out separate. I'm going to vote no on it.
Okay, we'll take up items 5A and 5B as part of the original motion. Any other discussion on the motion? All right, we're voting on 5A and 5B as action consent items. Ms. Hopper.
Margaret Brown,
Aye.
Henry Jones,
Aye.
David Miller,
Aye.
Irena Ortega,
Aye.
Ramon Rubalcaba,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have a motion made by Teresa Taylor, seconded by Ramon for items 5A and 5B. All ayes.
Thank you. Brings us to 5C. We'll have the same motion and seconder. Ms. Brown, did you want to speak to it before we vote?
No, I'm fine. Just voting no. Thank you.
All right, Ms. Hopper.
Margaret Brown,
No.
Henry Jones,
Aye.
David Miller,
Aye.
Irena Ortega,
Aye.
Ramon Rubalcaba,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have the motion being made by Teresa Taylor, seconded by Ramon Rubalcaba. All ayes, 1 no, made by Margaret Brown on agenda item 5C, minimum standards for health benefits plans, amendment of regulations.
Thank you, Ms. Hopper. Brings us to item 6, information consent items. Do have a request to withdraw or pull off 6C for further discussion. So at that point, we're on 6C to discuss. Ms. Taylor, please.
Thank you. I just wanted to have Mr. Mold or whomever to talk about the movement between plans, what kind of what the results were. I mean, I've got the table here, and I know we've all got the table. What were the drivers of these movements, if you don't mind?
I mean, I can tell you at a high level, and I have Karen Polish, who is the acting division director overseeing HPRA here for specific questions. But as a general rule, we saw, we saw some movement, but not substantial movement, which is pretty par for the course, both with CalPERS and with health insurance. Generally, we've I mentioned this to Mr. Jones in the past, but we've done a little bit of work. We've had a researcher from Cal looking at our members who are even more in the term of art is sticky. So people at CalPERS, people generally tend to stay with their health insurance. People at CalPERS even more so. We're looking at some of the reasons why, because ultimately we want to see our members shop. In any particular area, it's often the case that there's a better deal out there, and we're forever trying to bring better deals into the various regions. But part of having that be significant is having people take them up. So, it's a hard nut to crack. Having the options is important, but CalPERS members tend to stay with their plans unless they're pretty significant changes in pricing.
Okay, it looks like, I appreciate that, Mr. Moles. It looks like it was kind of a lot of movement based on what I'm seeing here. So, for example, it looks like the PERS plans, there was quite a bit of movement. I imagine that was cost.
Right.
The other plans though, and I don't know if it's because we had different choices, there seemed to be a lot of movement out of and into different plans. But basically what you're saying is most of it is cost driver.
Yeah, I mean, not candidly, not as much as we would assume given price differences. We certainly have seen some, but Karen, do you have anything you want to add there?
Ms. Taylor, Karen Polish, CalPERS team member. It's actually very interesting that the overall percent of change was lower in 2020 than in previous years. I went and took a look after we spoke with Mr. Rubakova, and in 2017, it was close to 5% overall movement, in 18, about 6.5%, in 2019, almost 5%, and then for 2020, only 3.1%. So we actually had less movement during the 2020 open enrollment than in the last couple of years. And as you saw on the table, the plan that gained the most members was the PERS Select. And so it feels a little bit like that's not wanting to be the first one to jump into the new plan design, right? After they see it in action for a little while, we had a little bit more movement into that plan. But as Dawn mentioned, our members are very sticky. We have a hard time getting folks to recognize the value of a plan change for them. People tend to stay with what they have. We've never really seen big movements, and it actually was a little bit less movement than we've seen in the last few years.
Okay, great. I just kind of wanted to highlight that for our stakeholders a little bit, because we do talk about it every year, but we don't get into the granular part of it. So I appreciate it. Thank you so much.
You're welcome.
Thank you. That brings us to agenda item 7, action and agenda items, competition study. Mr. Moulds.
Great. Good morning again, Mr. Chair, members of the committee, Don Moulds, CalPERS team. Item 7A is a culmination of work we've been talking with you about for a while now. It's a competition model for our basic health plan portfolio. We embarked on this work to provide data and information to guide CalPERS decision-making in determining the right mix of plans for optimal competition across our various regions. As we've discussed before, the right mix of plans and plan types can maximize competition among insurers as well as between insurers and providers, which can lower prices. And the wrong mix can have the opposite effect, driving up prices. Last year, we engaged Limor Daphne, professor of business administration at Harvard Business School and academic affiliate at Bates White Economic Consulting, to build CalPERS an economic model that predicts the impacts of changes in basic plan offerings on overall health plan premiums. The competition model anticipates member migration among plans, competitive dynamics within geographic areas, and overall impacts on regions as well as statewide. What we've been referring to as the competition study is an economic model that was finalized in January and that the CalPERS team has used this year in our evaluation of health plan proposals. We've also been using it to better understand the competitive dynamics in our basic plan portfolio generally, both to think about what types of new plans or plan expansions we may solicit in the future, and in anticipation of our next health plan contract cycle, which will culminate in new plans and plan renewals that will become effective January 1st, 2024. Preparations for that cycle will begin later this year, shortly after your approval of the 2022 rates. By way of reminder, at the November PHBC, we presented several new plans, service area expansions, and benefit design proposals for 2022. The board approved all of the team's recommendations, but for 3 of them, the approval was contingent upon confirmation that the competition model, at that point still under development, affirmed that the net effect of the proposals was that they would improve competitive dynamics and ultimately create downward price pressure. In November, we indicated that we would be bringing that analysis back to the board in March, which is what we're doing today. In addition to the plans that you approved provisionally or outright, in November, we briefly discussed one additional new service area expansion that was submitted just under the wire. That proposal was put forth by Western Health Advantage. They are proposing to expand their basic HMO plan into Humboldt County. Because that proposal was submitted too late to bring to you formally in November, we only alerted you to it. We didn't ask you to approve it. So I'll be returning to it later in this presentation, and we'll be asking you to approve it formally. With that, I'll turn things over to Dr. Daphne, who, as you may recall, joined us for the board offsite last July. Dr. Daphne is the Bruce V. Rauner Professor of Business Administration at Harvard Business School and serves on the faculties of the Harvard Business School and the Kennedy School of Government. She's a leading expert on competition and U.S. healthcare markets. Dr. Daphne is going to share a little more about the model she built with her colleagues at Harvard and Bates White, as well as key findings. Following her presentation, I'll walk you through the findings of the competition model as they relate to the 3 plan expansions you tentatively approved in November, as well as the proposal to expand Western Health Advantage into Humboldt County. So I'll turn it over to Dr. Daphne.
Hi, well, good morning to you. Good afternoon over here. Thank you, Dr. Molds, Chair of the board and board members for inviting me to speak today. The first couple of slides I have here are basically just to refresh where we were when I last spoke to this group in July. So the next slide gives a bit of information about the background for this study. So CalPERS approached me back in fall 2019 to ask if I could help develop a model to assist in developing and refining plan offerings. My expertise is competition in healthcare markets, and Dr. Molds expressed a particular interest in understanding how CalPERS could, through its plan offerings, potentially spark more competition among providers and insurers in order to serve your members and generate greater value for them. As I mentioned in July, I asked an economic consulting firm, Bates White, to assist me with this project. Through them, we added 2 excellent economists, Robin Lee, a colleague at Harvard's economic department, and Zenon Zabinski, who is a principal at Bates White. Next slide. All right, so the goals that we agreed upon after a little bit of back and forth are listed right here, right? First of all, we needed to understand and model all of the moving pieces, how they come together to generate enrollment premiums and value. I'll use the term utility. Economic utility is just an index of consumer satisfaction for members. And once we had built the model, we took it out for some rides which we formally call simulations. And we did that. We modeled both historical changes to see how well our model predicted them, and also future changes in order to assess what might happen under alternative scenarios. And those scenarios, as Dr. Molds mentioned, included the specific expansion proposals that are going to be discussed in a couple of moments. But we really tried to focus as well on using the model to develop some broader insights. I should note that the model itself incorporates CalPERS planned changes as relevant, including risk adjustment. So the next slide gives you a sense for the study design where we were in last July was in the data step. There's quite a lot of data de-identified that we utilized in stage 1 to build what we call a choice model, where we use data on the choices, actual choices of members, member characteristics, including, of course, location, but also family, also risk scores, and plan characteristics to drive, to figure out the drivers of the choices that they were made. And I should note the plan that you chose last year is also a relevant predictor, as has been discussed earlier today. There's a lot of inertia, so that's reflected in there. And we tested and refined the model by comparing predictions of the model to actual choices, for example, using the data from 2014 to 2019 to estimate the model, predicting what happened to enrollment in 2020. And we did pretty well in terms of making those predictions. All right, and then the next stage 2 in orange here, oh, not the next slide, sorry. So next stage 2 in orange, we estimated a model of plan costs, medical and pharmacy costs, which depend on characteristics of the enrollees, in particular their risk scores. Also regional differences in the costs of care, cost differences across plans. We then, in order to obtain premiums, added in CalPERS negotiated payments with these plans that yield total premiums. Kaiser is more complicated, but we have a way to address that. And as I noted, we implemented risk adjustment both in 2022 and 2023, where it's complete. And then you get to do stage 3, which is the fun part, putting all the moving pieces together and feeding alternative proposals through and simulating what would happen, which generates your insights. So next slide. All right, so this tells you a little bit more about the simulations that we did. We considered the 4 plan expansion proposals that Dr. Molds will be discussing. We also tried a number of hypothetical scenarios, which we won't take the time to go through in great detail or really much detail today, but to generate some insights, and that's what I'll talk about. There were a range of outcomes that we evaluated. In particular, subscriber utility. Now, utility, as I mentioned, is that index of consumer satisfaction that reflects the benefit to a consumer of their choice, net of the premium expense. So it's possible that you choose a higher cost plan, but generate a great deal of satisfaction from it, such that your net utility is potentially higher than were you to select a lower cost plan. It depends on your preferences and on the cost differences and on your value of income, which is all built in there, right? With individuals from households in zip codes with lower median income likelier to be more sensitive to premiums than others. So we have a good deal of variation in subscriber preferences. We also looked at what happens under these scenarios to subscriber premiums, which depend also, of course, on what happens to state employer contributions, which in turn is a function of which plans are popular and what their premiums are. So there really are a lot of moving parts. We can go to the next slide. All right, so where do, what are some big conclusions? You can feed things through the model and generate, you can do what ifs. But based on our various simulations, we conclude, and you will see this in the plan expansion proposals, that variety can be quite valuable, particularly when the variety that you're offering that you're adding isn't currently available. So the example here is the Western Health Advantage proposal in Humboldt County. They don't have access to a narrow HMO, either a narrow or a broad HMO where they live, and that addition really does generate significant consumer benefit and create some price pressure in that marketplace. Another observation is really this interdependence across plans and between plans and the state or employer generally contributions is, don't want to oversimplify and say it's tricky, but it's really tricky. For example, you introduce a plan and it attracts relatively healthy subscribers, and those subscribers have fairly low costs, so the premiums of that plan are relatively low. That is true even after we implement risk adjustment. Risk adjustment just isn't perfect, okay? So in that case, then the premiums of the other plans rise, okay, which could diminish the utility of subscribers who continue to stay in those plans unless the state contribution rises enough to offset it, in which case the state is paying more. So you have to think about that. So that's the linkage. On the other hand, if you were to introduce a plan and it attracted a lot of subscribers, then a rival plan might reduce its premiums in order to maintain its market share, and then premiums could go down for others as well as for the state, right? So it really depends on what you predict the reaction is going to be of large rivals in this marketplace to plans that you introduce, and so our model allows a variation in the strength of that response. And as you are aware, because of the method of premium setting, change in one region can affect subscribers that are not there at all, and we can see how much it affects them. So our simulations can show, if you do something in Humboldt County, what happens to the rest of the state. So it's a pretty neat tool. And I think the plan is now for Dr. Moulds to show you the expansion results.
Great. Thank you, Dr. Daphne. If we can go to slide 2 of my presentation. Are we on slide 2? Great. So I'm going to start by walking you through the timeline. Then I'll discuss the proposals that were approved contingent on the competition model and the new plan expansion for your action today. If we could go to slide 3. Here is a reminder of the timeline for health plan proposals. You'll recall we moved up the timeline for approving proposals from the spring to the fall to allow for transparency in the rate development process, but also because it was challenging to analyze the full impact of new proposals at the same time we were developing rates. In August 2020, we asked our health plans to submit proposals for any changes to their existing plan products or for adding new plan products, and to provide CalPERS with applicable pricing, provider network and coverage area details, as well as benefit design information. The carrier submitted proposals in September. At the November PHBC, we brought the recommendations for plan proposals for your action. All were approved, as I mentioned, although 3 were approved contingent on the results of the competition model. 2 are pending regulatory approval from the Department of Managed Healthcare, and 1, Blue Shield's proposal to expand its Trio health plan into Monterey is contingent upon both ongoing negotiations with Community Hospital of Monterey Peninsula which is the only hospital in that county, and DMHC approval. In February, the CalPERS team took into consideration the results of the competition model. I'll walk you through the outcomes of that analysis next. If we can turn to slide 4. The plan proposals that were contingent on the competition model, we're sharing the slides you approved, in November with the update of the results of the competition model. For the Blue Shield proposal to re-enter Access Plus into 8 of the 9 Bay Area counties, the model suggests the proposal will significantly benefit Bay Area members by increasing plan choice, by creating competition among health plans in the region, and by putting downward price pressure on plans in all 8 Bay Area counties. As a reminder, Blue Shield exited the Bay Area starting in the 2019 rate year. It proposed re-entering the Bay Area contingent on the reintroduction of risk adjustment that was approved by the board last November. Next slide, please. So Blue Shield proposed to expand its Trio Health Plan into 4 counties. Those were Monterey, Orange, Santa Cruz, and Stanislaus. The competition model shows that this expansion will increase competition and could create modest downward price pressure in the 4 counties. As I mentioned, negotiations for the Monterey expansion are ongoing, and because there is a chance those negotiations may not be successful, we asked Dr. Daphne's team to analyze the expansion proposal with and without Monterey. The collective analysis is that either version of the expansion will create more choice, more competition, and favorable pricing. Next slide, please. United Healthcare proposed its signature value Harmony basic HMO in 5 Southern California counties: Los Angeles, Orange, Riverside, San Bernardino, and San Diego. The competition model shows that this new proposed health plan provides members a low-cost alternative HMO option. Furthermore, this new proposed plan should increase competition and may result in lower prices in each of the 5 Southern California counties. In each of these 3 plan proposals, the competition model showed increased competition and the potential for downward pressure on pricing. Again, no action is needed on these proposals as you approve these in November pending this update. Next is the new plan expansion proposal for your action. Next slide, please. Western Health Advantage is proposing a service area expansion into Humboldt County for their basic HMO plan. Will create the first low-cost HMO available in Humboldt County. And the competition model tells us that this could cause significant downward price pressure in Humboldt County. To say that we're very excited about this plan expansion. Not only does it check all of the boxes from the perspective of our competition model, but it will also offer members a meaningful new choice in a rural California county. By way of reminder, the Western Health Advantage proposal is contingent on regulatory approval from the Department of Managed Healthcare. The team recommends board approval for this service area expansion. Next slide, please. This table summarizes the plan proposals presented today. And then next slide. And then for next steps, the CalPERS team recommends approval of the Western Health Advantage Basic HMO Humboldt County Service Area Expansion proposal. We'll incorporate all of the approved plan proposals into the 2022 rate development process. You're going to get a first look at 2022 premiums in a May close session. We will be bringing preliminary premiums to you in June open session, and final health plan premiums will come to the board for approval in July. Approved premiums will take effect January 1st of next year. And that concludes my presentation. I'm happy to answer any questions.
Thank you. I know we have a couple of callers on the line, but I have Ms. Green-Ross first.
Yes, Mr. Maltz, I just had a question about the consultant's unable to, maybe it was a timing issue that we didn't, and it wasn't, they said it didn't have a huge impact, but not having access to our local employer participants data. I thought we had all that in our database.
We don't, and Dr. Daphne, if you want to elaborate.
Yeah,
but
sure, absolutely. We have a lot of that information in the database. We're able to incorporate those lives in terms of predicting costs and observing choice. What we don't have access to is the employer contributions on their behalf, which means we're guesstimating what the out-of-pocket subscriber premiums are. So we make use of them where we can, but we don't where we don't have the data.
Yeah, so it's the data we have gives a lot of, there are a lot of data points within that data, but not the data points. You know, we've talked about future iterations and the possibility of doing a call for that information. But you know, it is challenging given the sheer number of public agencies.
Right. For right now, we're assuming that their choices are similar to the choices that the conditional on all the observed characteristics that state employees would make. And their support in the data that they look fairly similar, again, conditional on having certain age and household income, median household income and the zip code, et cetera. But that would be a nice thing to build in.
Yeah, I misunderstood and thought that also would be public information.
We weren't able to get it. Yeah. It's actually surprisingly complicated just to even figure out for which members in there was a lot of back and forth in your own data, what their, you know, is it 80, 85, 80? Anyway, there's a lot of moving parts, I suppose.
And if we have enough other data and it's not, and we can, and obviously if you can model and ballpark of what you have, I just wondered how much of the impact that would have been on changing the results in any way, shape or form, but it sounds like it wouldn't have made a difference.
You know, we make some assumptions about that population because we need their total enrollment, right, to figure out costs, et cetera. But my comfort level is pretty good with the volume of data we have for all the other pieces. So I feel like, I mean, my advice is that it's probably the juice isn't worth the squeeze.
Great expression. Thank you very much. Appreciate it.
Thank you. Mr. Rubalcaba.
Thank you, Mr. Fechner. Very good presentation. And Dr. Daphne, I'm very impressed with the model. A couple of times you mentioned subscriber utility or economic utility, and I guess as layman comment, the value to members. And I'm always interested in how do you call it index of consumer satisfaction, but it's always hard to understand how people measure value, because I think a lot of it is influenced by marketing from not so much from the provider. I'm sorry, from the either depending from the provider or the carrier, and sometimes they confuse. They want this plan, not understanding that it's plan design that they're really talking about. And so my question is, because one thing that's very unique to what the action we took in November is we're adding, expanding or adding new narrow networks. And narrow networks depends I'm interested in how the members perceive it, because on one hand, it does bring you a lower priced HMO, and it may be the same physician you had, but for other people, there will be disruption. But yet they're gaining, some people may not want to move because their physician, they have to change physicians. So they see that disruption as a bad thing, but some people will see the price a better thing. And yet the insurance carrier, they will argue that the narrow network is a better net value because they have more control over the provider, and somehow it's a better contract and there's better outcomes. So members don't tend to look at outcomes, I don't think. They look at other things. So I was wondering what your studies on, how your model qualifies consumer satisfaction, and especially on this, if you could speak to the neural network dilemma, because some people see that as a good thing, some people see it as disruption, and it does impact, if flight does impact the phone network, for example. I'm familiar with regions where it's the same insurance carrier providing a phone network and a narrow network, and you see the flight, and depends on the employer whether they want to keep the differential the same or let it flow and kill it. And sometimes I think it's introduced just to compete with a larger HMO that they'll argue is still bigger. Their narrow network is still bigger than Kaiser, for example. They'll say that. So I'm just curious how your model compensates for that, and it's just intriguing to me to do a model this stuff.
It's a fascinating discussion, and I will right off the bat tell you model can't fix everything. But let me just tell you what it assumes. So it assumes that your observed choices, that the choices that people make are Mr. Rubalcaba, right. Okay, so if it is marketing that is why you, or if it is that you like the lobby at Kaiser, if that is why you choose it, then it is your choice. And if it's the case that we observe a set of individuals facing a certain choice set, and there's a Mercedes plan and a Mercedes price, and there's a narrow plan and a narrow price, and they pick this one, then we say that they are more satisfied than they would be from this one. Now, as you point out, that might not involve true quality, but just as with other consumer products, we don't, I don't know if this is appropriate to say, but we don't judge. We say, you want that car, you can pay for that car, you have that car. Now, I think a way we can assist people in making choices that they aren't after the fact unhappy with is giving them information about the quality, right? I know, because I can look up all kinds of car ratings, what I'm buying, right? Okay, and I'm never buying a Mercedes. But it is much harder to do with healthcare, and I might not currently be experiencing a need for knee surgery, so I might not know about the limitations on how many knee surgeons I can see, and so I might not value that. So that's the role of the employer in trying to provide that education. Although at some level, people make choices. They don't save for retirement, and they maybe don't pick broad networks plans, even if later they perhaps we, if we were making the decision, we would think they should. So the concept of utility is based on what you choose and what people who look like you with your risk scores and location, et cetera, choose, and what you chose last year. Because a lot of, you have a fairly low turnover population. You asked the question about narrow networks, which I think is a really interesting discussion. What I would say is the following, which is, because I've studied narrow networks, in particular on health insurance exchanges, for the individual market. It is, of course, the case that lower income individuals are more price sensitive and more likely to pick cheaper plans. So it's got distributional impacts. On the other hand, and and they may not be aware that they don't have as broad a choice of providers, or if they are aware, they aren't, able to be in a position to make that trade-off. What I will say is that broad providers, the other providers who are left out, have a greater incentive to contain their costs and stop, say, merging in order to raise prices if there is a threat in the market. So it's not just about limiting choice. It's also about injecting consumer competition. Just as Mercedes looks around and says, hey, Lexus is out there offering a pretty good car at a lower price. That's the same idea, which is, wait, that's a pretty good narrow network. It has access to such and such academic medical center for these kinds of things. Maybe I really can't raise my price. So rejecting narrow networks because it does have that trade-off also has market implications.
No, I find that fascinating. But I don't want to prolong the discussion, but I would just speak to one item you said about how narrow networks tend to lower income people are, of course, sensitive to price, but also access is an issue. We dealt with this. I'm from Southern California. Our members tend to live in a corridor, like from downtown down to the Long Beach area, and the lower income people and they don't have access to neural networks because their plans tend to be older, and so neural networks tend to go with a higher tech, more developed, more innovative medical groups and hospitals. So I think it depends, but
Yes.
but nonetheless, I do want to thank you and Mr. Molds for bringing this competitive study, because that helps reaffirm our hunch or decision that these expansions and these new plans are worth it. Thank you very, very much. Thank you, everybody.
Pleasure.
Thank you. Mr. Miller.
Yeah, thank you, Dr. Daphne and Mr. Molds. Really, I think most of what I wanted to ask was asked by Director Rubalcava. This whole issue of, the stickiness of people and how their perceptions of, what you describe as subscriber utility, in terms of the way we may be impacted, as in terms of costs, and in terms of costs, particularly for our employers, when people seem to be so very much influenced by the brand management and the advertising by some particular providers, particularly some of these providers that are very high cost, but that despite, if you look at real quality measures, kind of empirical measures, CMS quality measures or something, they're not proportionate in terms of they really, it's like the advertising, the impression people have and make their choices on is way out of proportion to any real kind of tangible benefit in terms of healthcare delivery, in terms of quality by objective measures and cost. And it's hard to see how we can kind of get a handle on that when, even if we published a full panel of measures of clinical excellence, frankly, I think many of our constituents are much more influenced by the ads they see on TV and the shiny facilities and this reputation and brand that has been built. And so, yeah, it's almost more a comment than a question, but if you have any thoughts on how we could address that, because it really impacts us, our constituents, and our employers in terms of their choices and what it costs us.
I have a thought, but it's a complicated one, but it's what CalPERS is famous for. Among academics, I'm sure you're famous for many things, but is reference pricing, where you say this is a price where we can get something at good quality, and then the consumer bears the difference in the cost, and then they can choose, do we want the shiny facilities given what it costs. That said, you have a certain formula for your contributions, a very complicated one, Ms. Greenross. So I understand that a change like that is pretty huge, but it's very difficult without having the consumer bear the difference in cost for these things to get movement in their choices.
Thank you.
Thank you. Ms. Taylor.
Yes, thank you. Thank you for this presentation. My members have a lot that are in Northern California, in the rural areas, and in the very south of the state, in the rural areas that work in our prisons and places like that. So I'm glad to see that we are expanding outside of maybe some of the more populated areas, such as Stanislaus and Humboldt. I thought, and I cannot remember for sure which plan it was looking to expand. I think we got this report in November, Mr. Molds, to Lassen and Shasta?
Lassen, and I believe it's Alpine. That's Blue Shield Access Plus.
I didn't see it there.
And we approved those. Those were not plan expansions that we needed to run through the competition analysis because there were not HMOs in those areas. So those were approved in November.
Okay, so those were approved in November.
Correct. There were a bunch of
Alpine and Lassen.
let me double check that it's Alpine and not Shasta. Karen, do you remember? Is it Alpine or Shasta? I should know that.
Yeah, I'm also looking.
It's okay. It's okay. If you can get back to me, that's fine. You don't have to find it right this very minute. And then I just had
For not distinguishing Alpine and Shasta. It's
it'll make people mad, I know.
the people who live in Alpine and Shasta. Yes,
They're both beautiful though. So
they are. Just part of the challenge.
have we looked at, so I have a lot of members that work down south, all the way at the border. Have we looked into, any of our plans ever looked into going down that far into Southern California?
So we have pretty good penetration in the southern parts of the state. There tends to be more competition in those areas.
This is like Donovan State Prison. So we're looking at
So Imperial or?
yeah, it's further east.
Yeah, so in Imperial, so in San Diego, we have several plans. I'll get back to you with the list of plans, but I think Imperial has pretty good penetration as well.
Okay, I appreciate it.
Yeah, I know Saluti Moss, for example, is an Imperial. So there's some interesting plans down there.
I know Saluti Moss is down there. I thought it was just LA though. Am I wrong? That's Imperial?
I think it's an Imperial as well.
Okay. And then the Lassen and Shasta/Alpine, there was no approval that needed to happen through DMHC or anything?
No.
Okay, cool.
On the Blue Shield Access Plus expansion was Lassen and Shasta.
And Shasta, you got it right and I got it wrong.
Got it, thank you.
Lassen and Shasta.
Thank you very much.
Very good, thank you. Seeing no other requests, we do have a couple of requests from the audience. Mr. Fox.
Yes, Mr. Chair, we have two callers on item 7A. The first caller is Lisa Bocast from SEIU.
Thank you.
Hello, can you hear me?
Yes.
Okay, thank you for this opportunity to speak. As I was introduced, I'm Lisa Bocast. I'm a state employee and a member of SEIU Local 1000. I wanted to share my story today to provide concrete examples of the type of problems that the state workers are facing and hope that you continue to address these problems. And I am from Shasta County, so I was excited to hear some of the new changes. In 2017, my son needed surgery. And I made sure I got all my pre-authorizations with both the hospital and the surgeon well in advance. Surgery day came, everything went well, and he healed with no complications. However, about 3 weeks later, I got a bill for $23,000. The entire surgery had been denied. And when I called the hospital, I was referred to the insurance company. And I called and I questioned why the surgery had been denied, as I had my authorizations, and I was informed that the anesthesiologist was not in network, so the entire surgery was denied. And then I asked how I would have known this, because I didn't even know which anesthesiologist would be assigned to my son's surgery until about 5 minutes before the surgery. I was told that it was my responsibility to check to see if the doctors treating my family are in network. And I asked how I was to know this, and I was told there's an app for this. So I have 5 children, 4 are boys. Boys fall down, they break bones, they split things open. So what they were telling me is that if my 9-year-old falls off his bike and needs to go to the hospital, I'm supposed to ask, excuse me, doctor, what's your name? Check the app. Oh, I'm sorry, you're not in my network. You can't treat my child. Then go to the next doctor and again, ask his name, check the app, and verify whether or not he was in my network. This is ridiculous as a parent or a patient. Our members should not have to jump through these kinds of hoops to get treatment. This is unacceptable. As it turns out, Reading has 2 hospitals. Both of them are in network. However, few, if any, of the doctors employed by these hospitals are in network. Another example of rural healthcare issues happened in July of 2020. I was scheduled for an endoscopy and a colonoscopy by my doctor in Chico, which is 90 miles away from where I live. And it was scheduled at St. Elizabeth's Hospital in Red Bluff, which my doctor had rights at, which is about 30 miles away from where I live. I went in for my pre-op appointment on Friday and was cleared for this appointment for the following Wednesday. On Monday, I got a call from my doctor's office telling me that the hospital was refusing to treat me because I did not live in Tehama County. I live in Shasta County. Now I was scrambling to reschedule this procedure as it was a prerequisite for Anthem Blue Cross for an upcoming scheduled surgery. These are just a few examples of the struggle of healthcare in rural areas. Thank you for your time and for listening. Thank you.
Thank you for your comments. And Mr. Moulds, could you have somebody reach out to this member and find out what's going on? We're dealing with providers, and it doesn't sound like they're actually providing if our members have to try and look up this information themselves. That seems to be out of the scope of what our patients and members should be dealing with.
Yeah, absolutely. I was just going to ask Mr. Fox to share my information, and we'll be in touch with her. That's completely unacceptable.
Excellent. Thank you. Mr. Fox.
Yes, Mr. Moulds, we will do that. Next caller, also from SEIU, Laura Slavic.
Good morning. Hello, good morning. Thank you for allowing me to speak this morning. So my name is Laura Slavic. I am a registered dental assistant at Pelican Bay State Prison. I have been providing this service for the state for almost 9 years. I live in Del Norte County, where we only have one hospital, Sutter Coast. Last February, my 14-year-old son, Kane, who, by the way, has an extremely high pain tolerance, was throwing up and was complaining about tremendous pain in his groin area. I called his physician, and they were able to get him in right away. Once we got into a room and the physician was able to examine him, the physician explained that he might have testicular torsion. The PA said that this is a time-sensitive matter, that he could possibly lose one or both of his testicles if surgery was performed. The PA then called over to Sutter Coast to see if there was a surgeon that could perform the surgery if surgery was needed to be done. The answer was no. So instead of wasting time going to Sutter Coast and then possibly having him life flighted out or whatever they thought was most appropriate to get him this surgery, I rushed my son to Grants Pass, Oregon, which is almost 2 hours away on a very curvy road. The PA had called over to the Grants Pass Hospital and had set up and let them know that we'd be coming and what was going on. So when we arrived, they were ready to take us back and do all necessary tests to determine what was going on. Lucky for my son, he did not have to have surgery. How can the only hospital in a 2-hour radius not be equipped to handle the community's needs? The fact is, they could not accommodate something that was extremely time sensitive. If my son did have testicular torsion, that 2 hours it took to go to the hospital would have cost him and changed his life forever. This is just the most recent encounter. I have plenty other experience that are far from satisfactory when it comes to Sutter Coast. And as our locals here in Crescent City and Del Norte County like to call the hospital, Slaughter Coast. Change needs to happen. Thank you so much for your time.
Thank you for your call and your comments. Mr. Moulds, anything to add?
No, except just to share my condolences for what sounds like an absolutely horrid experience. And I'd also like to be in touch to get some more details if that's possible. We'll have Mr. Fox connect us if the caller is willing to discuss them in more details.
Excellent, thank you. I have Ms. Taylor.
Thank you. I just wanted to make sure, based on Ms. Bocast's comments, I'm just kind of a little weirded out over the fact that you have a hospital that's in network and the physicians aren't in network. So I want to, and I know, Mr. Bowles, you said you're going to talk to her. Is that a normal problem within? I'm sorry.
It can certainly be a challenge. You know, the one of the, we've, Ms. Green and I have spoken quite a bit about some of the challenges with surprise bills, particularly in regional, in rural California, rather. And, you know, our HMO enrollees are protected by very strong state legislation. We are very, very pleased to see the legislation that passed Congress at the end of last year. It will go into effect not until January 2022. So our PPO members are still vulnerable to this. You know, we are certainly willing and eager to get involved to make sure that we've done everything we can do to protect them. In 2022, there will be significant protections for our PPO members that aren't exactly the same as the protections for our state members, but are pretty close. In some cases, a little bit stronger, in some cases, a little bit weaker. You know, there's still work to be done on the federal level on this issue. We need to bring in ground ambulances under the surprise billing protections, but they're good. They will help. But this is a really nefarious, horrible problem, and I hate hearing stories like this. It is incredibly frustrating.
Okay, so let me, I mean, that's great. So what that means is these folks that are in our rural areas have to have the PPO because that's all they can have. But is this law, the federal law, going to force these physicians to actually enter the networks because they're just not going to get paid? Is that how, hopefully, what happens? Because surprise billing law?
Yeah, so you know, the network should include you know, reasonable services. In some of these rural areas, the coverage can be more challenging than in other areas. Del Norte County is an extremely low population county, which is where you often see some of these challenges. You know, the federal law will go a long way towards protecting certainly from the surprise billing, the network adequacy laws that affect the state health plans, our HMOs, are not in effect for PPOs for our self-insured side. But part of the reason that I want to be in touch with her is that this sounds like a shortcoming in the network potentially, and I want to make sure that if that's the case, it's remedied.
I appreciate that. And yeah, I just want to let Lisa and Laura know that definitely we want to.
Please do.
Yeah. So I appreciate it, Mr. Mills. Thank you.
All right. Thank you. Seeing no other requests to speak, this is an action item. What's the pleasure of the committee?
Move to approve.
Second.
Who was the motion?
Oh, Karen.
Okay. A motion by Ms. Green-Ross, seconded by Mr. Miller. Any discussion on the motion? Seeing none, Ms. Hopper, please.
Margaret Brown,
Aye.
Henry Jones,
Aye.
David Miller,
Aye.
Elena Ortega,
Aye.
Ramon Rubacava,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Green-Ross for Betty Yee.
Aye.
Mr. Chair, I have a motion being made by Karen Green-Ross for Betty Yee, seconded by David Miller on item 7A, competition study and 2022 new plans, area expansion and benefit changes.
Excellent. Thank you very much. Moves us to agenda item 8A, information item update on a retiree cost of living adjustment. Mr. Sweeney.
Good morning again, Mr. Chair and members of the committee. Anthony Sweeney, CalPERS team member. And I would like to take this opportunity to introduce you to Kimberly Polito, who succeeded me in the role of Division Chief over the Retirement Benefit Services Division. And she's going to be presenting the cost of living adjustment item to you today. So I will turn it over to Kimberly.
Good morning, Mr. Chair and members of the committee. Kimberly Polito, CalPERS team member. I'd like to start by congratulating Mr. Fechner and Mr. Rubalcava on your re-elections to your chair and vice chair positions. Agenda item 8A is our annual information item update on the retiree cost of living adjustments, more routinely referred to as COLA. A retirement law provides for the payment of an annual COLA each May to all eligible retirees based on the rate of inflation as measured by the CPIU, which is a consumer priced index for all urban consumers. A retiree becomes eligible for COLA in the second calendar year of retirement. Therefore, members who retired on or in 2019 or prior are eligible to receive a COLA benefit this year. For the year ending 2020, the rate of inflation, as measured by the CPIU, was 1.23%. Approximately 95% of our retirees are contracted for a 2% COLA. Those eligible will receive at least a 1.23% adjustment on this May 1st retirement check. Because of lower inflation in some previous years, members who retired in certain years will receive the full 2%. We also have less than 5% of retirees who are part of employers who have contracted for a 3%, 4%, or 5% COLA. Those in this group will receive at least 1.23% as well, up to their contracted amount. This agenda item provides a helpful chart for retirees to determine what they should expect for a COLA increase based on their retirement date. This information has also been shared with our stakeholders and is available on our newsletter and on our website for our members. That concludes my update, and I'm happy to take any questions.
Thank you very much, Ms. Polito. I don't see any questions, so must have been a great presentation. Thank you.
Thank you very much.
Anything else on this, Mr. Sweeney?
Nope, that's it, Mr. Chair. Thank you.
Very good, thank you. Item 8B, summary of committee direction. Mr. Moulds.
So I have two. The first is to do a behavioral health briefing at a future PHBC meeting. And then the second is to keep this committee informed of any changes that we're seeing in our future liabilities in the long-term care program.
Thank you. I think you've got it. And when we talk about the behavioral health, when you bring that back, I, for one, am not interested in having the providers come back and talk to us again like talking heads. I'd rather see you and Dr. Logan do the heavy lift and then bring us back the information on each plan.
Happy to do that.
Very good. Thank you. Next item is the public comment. Is there anybody for public comment, Mr. Fox?
No, Mr. Chair, that concludes public comment.
Very good. Thank you very much. Next up will be the Board Governance Committee. Mr. Jones, what time would you like to start?
11:30.
All right, 11:30 for Board Governance. Everyone take care. Thank you for joining us for the PHBC meeting, and we'll see you soon.